Good evening, dear IADVL members. A very warm welcome to all our presenters and attendees. In keeping with the International Society's CME program from IADVL EC 2022 and the IADVL Leadership Pipeline program, today we bring to you part 2 in this series, which is the IADVL WDS program on interesting topics from the Women's Dermatologic Society speakers. Before we begin, a quick word about the WDS. The Women's Dermatologic Society was founded in 1973, and I just realized today that in fact they will also be celebrating their 50th year next year, so that's really cool. And WDS basically seeks to celebrate dermatologists in all their myriad roles as physicians, mentors, and leaders. Today, we are lucky to have with us some very, very gifted gems of WDS, all of them prolific speakers and distinguished leaders in their own right. I shall now invite Dr. Rashmi Sarkar, President IADVL 2022, to please give her presidential address.
Thank you so much, Surabhi. Well, a very warm namaste. Good evening, all the IADVLites. Good morning to all the WDS members in the USA. It's a really pleasure today to host the second in the series of the IADVL International Society CMEs, which was always a dream. And I'm just very happy that we are able to host the IADVL WDS webinar because this remains very close to my heart, a society which is very special. And I think a lot of Indians also know that, about the WDS. And I'd like to say a word of thanks to the President of 2022 of WDS, that is Dr. Mona Gohara, a very special friend of mine, and I have also seen her over so many years. Her sense of duty has been just unfaltering, and look where we are today. I'm so glad to be sharing my year of presidency also with Mona in the United States of America. Nothing could be more delightful. Well, the WDS stands for Physicians, Mentors, and Leaders. It has played a very important role, at least in my life and my development, has given me a very big anchor at a long time back. So I'm going to just share very quick pictures through my journey. So I'm going to share my screen. Are you able to see?
Yes, Dr. Slide show mode.
Okay, yes. Thank you. So let me start. This is the first picture when I got the International Travel Grant Scholarship from the WDS, which is still there, and a lot of people have availed this. It's played an important role in their career. This was way back in 2006. I was also invited faculty at the American Academy of Dermatology, and I thought that the WDS can help me to get this grant. So these are the International Travel Grant winners of that year. You can see the then president, Dr. Bonnie Elwiski, right in the center, a lovely person with whom I've had some leadership conversations. Many of us from different parts of the world, you can see along with me, Dr. Mukta Sachdev on the left, she's also from India. We are very proud to be getting this international travel grant. I could actually speak at the AD session because of this, attend the WDS networking luncheon, and it stayed with me for a long time to memory. Well, one thing led to another. I started working on various committees, and I worked also on the International Affairs Committee that time. And the president in 2009, that was Dr. Wendy Roberts, again, a very good friend as of now. We met during one of the meetings in New York when, in fact, she encouraged that if you want to bring WDS to India, why don't you think of having one? With that idea, we wrote letters, and she came for the first Indian WDS networking session. Many of you will remember this was way back in 2009 in New Delhi when a new chapter was open. This is the plaque of honor that she gave me. This is one of the most precious plaques that we have. Hence started the conversation around having this society in India. Although we officially registered it only in 2018, till then we were hosting meetings all the way. Every year people would ask question, Why a women's dermatologic organization? Every time we mention patiently that it's about celebration. Well, this is again a very precious picture through my journey, having served at many places. And here again, I'm there on the WDS board of directors. This is way back, I think in 2011, perhaps, or 12. You see a lot of people here. And Dr. Amy Peller was there as the president-elect, I think that time, and Dr. Janet Hickman, who was also there, Dr. Diane Burson, who will be there today. In fact, you do see Dr. Mona Gohara, the now president, second from the left. So, these are people who have been working consistently. So lovely picture, lovely memories. Then, of course, I've always worked with their Play Safe in the Sun. Play Safe in the Sun was something that the WDS did under Dr. Mona Gohara as well as Dr. Kavita Mariwala. I took some tips from them. They sent me these lovely bracelets, and we did it in a number of orphanages. We kept on doing it in community. Dr. Pearl Grimes, the president in 2019, she came to India, and together it was part of the Global Shelter project which he launched. We started doing it in houses, of destitute women or women of gender violence. So this is Dr. Pearl Grimes for you and me. She's really a forerunner in this kind of social work. We did a lot under this, and we've even brought it to the IADVille this year. WDS has been full of friends, full of memories, and they were generous enough to feature me in some of the women leaders in dermatology. This was a painting painted live by a Canadian painter at the World Congress of Dermatology in Vancouver in 2015. So this is my 30 seconds, more than 30 seconds of fame. On the wall, you see me representing Asia. Then, of course, Dr. Marsha Ramos E. Silva, South America. Then there is Dr. Krista D. Cooper from Europe, and Dr. Wilma Bergfeld, of course, from North America. A very special moment in time, a wonderfully delightful painting that captures all of us. Thank you, WDS. Well, this is what we do. I'd like to tell the members of WDS globally and also IADVille members. Members of WDS India celebrate the ILDS ISD World Skin Health Day. This is in 2018 in March. We also did it during International Women's Day. We brought it on International Women's Day. So what you're seeing is activities from all around India. You see many of the people featured here. You can see Dr. Surbhi Sinha here. Many of our other prominent people, which is there. This is our collage. So I would like to say that I gained a lot when women empower women, but a lot of men have also supported us women in India, and we are very grateful to all those very supportive men. Overall, a big shout out to all our friends in the WDS. We love working together with you. So thank you so much. So I'm going to stop screen sharing, and over to you, Surabhi, again.
Thank you so much, ma'am. While we are sharing, WDS is special for me as well, because I got my first international travel grant from the WDS to attend the AAT meet in 2010. So, okay, so now I shall be introducing all our speakers for today. There is a significant time gap, and we sincerely appreciate all of their efforts to be with us today. So starting off with Dr. Mona Gohara. Dr. Mona Gohara is Associate Clinical Professor of Dermatology at the Yale School of Medicine. She's a globally acclaimed speaker and is the current WDS president. Next is Dr. Pearl Grimes. She is Director, Vitiligo and Pigmentation Institute of Southern California and Clinical Professor of Dermatology at the David Geffen School of Medicine at the UCLA. She is also a past president of the WDS. She was president from 2018 to 19. Dr. Valerie Callender is Professor of Dermatology at the Howard University College of Medicine. She's also Medical Director at the Callender Dermatology and Cosmetic Center and Principal Investigator and Founder at the Callender Center for Clinical Research. She is also a past president of the Women's Dermatologic Society and of the Skin of Color Society. Dr. Diane Burson is Associate Clinical Professor of Dermatology at the New York Presbyterian Hospital. She has also been a past president of WDS in 2011 and 12. Dr. Latanya Benjamin is the current vice president of the Women's Dermatologic Society. Dr. Mara Weinstein Welles is also a board member. She's on the board of directors of the WDS. And last but not the least, Dr. Jenny Morez is the co-editor of the IJWD, that is the International Journal of Women's Dermatology. And she will be presenting her views on and her insight on the journal. Please note that all questions and answers will be taken up at the end of all talks, except Dr. Valerie and Dr. Diane Person, who will be taking them up immediately after their talks. So please keep writing in your questions in the chat boxes. We'll be taking them up. And I think it's over to you, Naveen. We can start off with the first lecture.
Hello, my name is Dr. Mona Kohara. I'm the president of the Women's Dermatologic Society. I want to extend a very big thank you to Dr. Rashmi Sarkar for inviting me to speak briefly at the IADVL WDS webinar series. Thank you so much. It is an honor to be here. Let me just share my screen briefly so that we can talk about some WDS initiatives this year and talk more about our organization. Thank you for your patience while I get the slideshow going. Here we go. Again, I'm Dr. Mona Kohara, and so happy to be here today. It truly is an honor. I'd like to just start by reading you the mission of the WDS, our mission and vision statement. The Women's Dermatologic Society was founded in 1973 by Dr. Wilma Bergfeld, an esteemed colleague of all of ours. It is dedicated to helping dermatologists fulfill their greatest potential and assisting them in making a contribution to our specialty and society. And we have indeed been doing that for almost 50 years. To achieve this goal, the Society relies on the active participation of its members, many of whom are in the audience today, who represent a diverse cross-section of professional subspecialties. The Women's Dermatologic Society is committed to issues relevant to women and their families. The mission of the Women's Dermatologic Society is to be the premier organization cultivating personal and professional development of women dermatologists dedicated to the excellence of patient care, mentorship, volunteerism, and leadership. I'd like to spend a couple minutes today talking to you about some of these initiatives that are referenced in our mission statement and encourage all of you to be involved if you haven't been already. I know many of you have been. Your leader, Dr. Rashmi Sarkar at the helm, has been a tremendous participant and member of the Women's Dermatologic Society, winning this year the Volunteer of the Year Award for all of her amazing contributions. So let's get started. Some of our events around education and networking. We every year honor a woman in dermatology or man who has been a legacy contributing tremendously to our specialty. This is fun because obviously it's a party and we all like to have parties and gather, particularly after COVID when we were deprived of that for so long. But more importantly, it's an opportunity for us as women to celebrate the contributions of leaders who have paved the way for many after them. And so this is an annual celebration we look forward to every year. Some of the past recipients have been Dr. Bergfeld, Dr. Drake, Dr. Pearl Grimes, Dr. Jean Bologna, Dr. Diane Burson, Dr. Susan Winkle. These are just a few of the recipients. We encourage you every year, if you're at the American Academy of Dermatology meeting, to come celebrate with us the WDS Legacy Awardee. During COVID, as you know, we couldn't gather and we couldn't have our traditional forms of education in meetings. And so the WDS launched what's called the Resident Education Series, where this was a series of virtual educational sessions for WDS members on a variety of topics. We've since had 52 events since 2020. All the events are recorded for our membership. And there's about 30, sometimes more than 100 attendees. The topics vary from vascular lesions of childhood, health disparities, LGBTQ patient concerns and issues, and complex medical dermatology and skin of color. We really try and make this series applicable, actually, not just to residents, but anybody in practicing dermatology. So again, as a member, if you are a member of the WDS or become one, I encourage you to look towards these. Other events that we've had are networking panels for young physicians and fellows and residents. We've had 5 networking events. Doesn't seem like a lot, but with COVID, of course, there were limitations. All of these events were virtual. Hopefully this year we'll be able to do more in-person events, because one of the tenets of Women's Dermatologic Society, or WDS, is networking, it's fellowship, it's getting to know each other, to help each other, both in our professional and our personal lives, to uplift and support each other. So we, as women dermatologists, can feel that as colleagues and as friends, we are linked arm in arm, helping each other to be the best version of ourselves. There have been the networking events this year or in the past years have surrounded applying to cosmetic fellowships, applying to DermPath fellowships, applying to Mohs fellowships. And so how to manage a practice. Again, these are topics that are salient to what we as women dermatologists face on a day-to-day basis. Now, mentorship is really the core founding factor of the WDS. The WDS, at least in American societies, dermatologic societies, was the first to espouse this whole concept of mentorship. It's incredibly important to our society. It really is a core tenet and pillar that we will never, ever part with. Since the inception of our original mentorship program, and this is a program that is for dermatologists at all stages of their lives, and they are, this is from, they help with careers to connect them with an expert so they can connect and really develop an area of expertise that they're interested in. Since 1993, there have been over 700 mentorship awards granted. Now, just at our last board meeting, we granted 28 more, so I'm going to amend that statement to 728. Mentorship is a key tenet of our organization, so if you become a member, we encourage you to take advantage of these opportunities. We also have editorial initiatives at the Women's Derm Society. We have editorial articles. There's a young physician's news brief that's a quarterly newsletter. There's PAC Pearls, that's by the Practice Advisory Committee, and this provides pearls on practice management. And of course, an advice column to our members called Dear Rose that helps academic dermatologists ask anonymous questions to other academic dermatologists and get them answered. Community service, like I said, Dr. Rashmi Sarkar won our Volunteer of the Year award this year. Community service, like mentorship, is a core tenet of our organization. Dr. Pearl Grimes initiated a shelter initiative where we WDS members and our colleagues go into women's shelters and teach them about how to take care of their skin, but not only their skin, but their bodies and their souls, to strengthen them and empower them. This initiative has been something that has been embraced across the country. Even in the past couple of weeks, we've had at least 10 of them. There have been 22 events in the past year, and we look forward to having more and encourage you, our sisters and brothers, all over the world to do something similar, as I know you have under the leadership of Dr. Rashmi Sarkar. Play Safe in the Sun, again, sponsored by some of our industry sponsors, is where we go into the public and screen for skin cancers. This has been something that has happened across our country that our membership has espoused. We as doctors and dermatologists want to own the space of skin cancer and skin cancer prevention. So this is a way we can contribute to our community and do that. Diversity, equity, and inclusion is also exceptionally important. As you know, dermatology in the United States is the second to least diverse specialty. only second to orthopedic surgery. So we have a committee that is dedicated to helping diversity initiatives in dermatology. We have had DEI panel discussions for underrepresented and in medicine med students. We've had 3 events in 2021, 2022, average of 85 attendees, topic examples, applying to dermatology residency, the interview process, and the match process. Again, we're very dedicated to uplifting men and women within this space who are underrepresented in medicine to help diversify our specialty and move the needle towards a more inclusive and equitable dermatologic field. We've also awarded summer student research fellowships for URM med students who can connect with somebody more senior in the field who can guide them. And we have another fellowship for residents for an aesthetic mentorship to help them seek out this space and enhance their career if this is an area that they are interested in. These are some of our already established initiatives: mentorship, networking, volunteerism, and of course, inclusivity. These are the tenets of the WDS. This is what Dr. Wilma Bergfeld had in mind when she started this organization in 1973, coming up on our 50-year anniversary. These are the things that our wonderful members like Dr. Rashmi Sarkar espouse and do in their everyday life to empower women. This year, as the president of the organization, I would love to expand some of our initiatives to include a global sisterhood so we can have a strong and good global sisterhood. Many thanks to you for inviting me on this wonderful occasion. Congratulations on a wonderful meeting. I look forward to seeing many of you in person soon. Thank you for the support and the opportunity of the Women's Dermatologic Society.
Hello, everyone. I am so delighted to be a part of this meeting and to receive this invitation from Dr. Rashmi Sarkar. So I'm going to be talking about what's new in vitiligo, and there are many exciting new treatments. I direct the Vitiligo and Pigmentation Institute of Southern California, and I've been involved in vitiligo research for many, many years. These are my disclosures. I have no conflicts in giving this talk, other than having been involved in many basic science studies and clinical trial protocols for patients with vitiligo for many, many years. So there are many studies from around the world on the quality of life of patients with vitiligo, which clearly document the profound psychological devastation of this condition. Patients experience low self-esteem, isolation, stigmatization. So I think no doubt vitiligo is one of the most psychologically traumatizing disorders in dermatology. We wrote a paper a number of years ago, which we called White Patches and Bruised Souls. And I think if you look at this image here, it really emphasizes the psychological devastation, despair that vitiligo patients experience when they look at that image in the mirror. So, where do we stand regarding the pathogenesis of vitiligo? The fact that we've been able to glean substantial new data regarding the pathogenesis of vitiligo, this no doubt has allowed us to move forward with multiple new therapeutic advances. So when we look at vitiligo, I consider it the trifecta from a pathogenesis perspective. It is the trifecta of genetics, oxidative stress, and autoimmunity. Richard Spritz has been at the forefront of genetics data, and we think that most of the genes involved are immune susceptibility genes. We know that the antioxidant redox system is aberrant, and we think that this is what leads to immune activation. The pathway that has been documented now from multiple labs around the world involves CD8 T lymphocytes, which migrate into the skin. They release interferon gamma. The JAK-STAT chemokine pathway is activated, and we have CXCL9 and 10, which continues the recruitment of lymphocytes, the cytotoxic lymphocytes, into the skin, which ultimately mediate the destruction of the melanocyte. So with that background, the basic tenets of treatment involve stabilization, repigmentation, and maintenance. And by doing this, we're able to impact. If we can achieve these things, we decrease oxidative stress, we decrease the aberrant immune activation response, and we're able to increase melanocyte growth, regrowth, and proliferation. Stabilization often involves the use of systemic corticosteroids. Narrowband UVB is also effective in stabilization. Supplements, antioxidants play a major role, and we'll talk about advances for repigmentation. So if we look at antioxidants, we don't think that vitamin D is a powerful antioxidant, but it's in addition to being a major player in modulating the innate and the adaptive immune response, vitamin D is also a powerful antioxidant. And there are multiple studies now from around the world which document vitamin D deficiency in patients with vitiligo. And this is a recent meta-analysis study of, they looked at 31 studies, and the vitiligo patients were significantly more likely to have vitamin D deficiency compared to control subjects. It was much more apparent in subjects who worked indoors and in an urban environment versus individuals who worked outdoors. And so this meta-analysis supported vitamin D deficiency in patients who have vitiligo. So I think as clinicians, it's very important that we consider measuring vitamin D levels and correcting vitamin D deficiency. And along that trend, this is an observational study chart review of 101 subjects with vitiligo. In this paper, they correlated baseline vitamin D levels in patients with vitiligo with repigmentation at 6 months. Active vitiligo at baseline was correlated with vitamin D deficiency, and at the 6-month follow-up, vitamin D, the vitiligo patients with normal vitamin D levels were able to achieve significantly greater repigmentation. So if we look at therapeutic approaches for vitiligo, therapeutic advances, certainly I wanted to take this moment to just emphasize that even if we look at the standard therapies that we use for vitiligo, these standard therapies are able to substantially repigment, if used appropriately, many patients with vitiligo. These therapies include topical and systemic corticosteroids, the calcineurin inhibitors, narrowband UVB phototherapy, the targeted lights for patients who have limited involvement, as well as our expanded repertoire of surgical therapies for vitiligo. Now, this is an exciting time for clinicians and patients because I think given our new knowledge regarding our abilities to work out the pathways involved in the pathogenesis of vitiligo, I think that we truly are on the cusp of opening new therapeutic doors that impact the lives of patients. So I'd like to spend the remainder of the time talking about some of these new advances: alpha-melanotide, the JAK inhibitors, prostaglandin F2 analogs. Certainly PRP in some studies has been shown to be efficacious, and we have a new generation of excimer lasers. So this is a new study looking at a titanium gain switch to laser in comparison to the 308 nanometer excimer laser. The advantage of the titanium sapphire laser is that it doesn't require a gas exchange as is required for the 308 nanometer excimer laser. This is a randomized controlled non-inferiority trial, split face, split body of 74 paired lesions in 21 patients with vitiligo. One side was treated with standard excimer laser therapy, the other side with the titanium sapphire laser. And if you can see here at the end of the study, both lasers were clearly comparable from an efficacy perspective in inducing repigmentation. And as I said, the major advantage of the titanium sapphire laser is that it doesn't require gas exchange on an annual basis. And you can see that the repigmentation on each side for the images that I'm showing you here are comparable. And this is one of our patients treated with the titanium sapphire laser. And you can see again at baseline, he has significant depigmentation of the mid-face. And at the follow-up photos, and this was achieved by 3 to 4 months, he had excellent repigmentation. I'll finish up with, but there are a number of new therapies in the pipeline for patients with vitiligo. Many of these are JAK inhibitors. Ruxolitinib, we've completed the phase 2 study. Tofacitinib is being investigated. There's a multiple kinase inhibitor being investigated. Anti-IL-15 biologics that block memory T cells that are responsible for reactivation of vitiligo. Heat shock protein gene therapy is in the pipeline, as well as new studies investigating afamelanotide. This is our study on afamelanotide, which was published in 2015. New studies should be coming to the United States very soon. Afamelanotide is now FDA approved for treatment in the United States of erythropoietic protoporphyria. A study was recently completed in Singapore. In our original investigation, afamelanotide, which is the synthetic analog of alpha MSH, it was used in combination with narrowband UVB versus narrowband UVB monotherapy. At 6 months, the combination group was substantially more efficacious compared to narrowband UVB monotherapy. If we look at the prostaglandin F2 alpha analogs, there are a number of studies in the literature, and new studies continue to be published on the efficacy of latanoprost and bimatoprost. Both these agents are prostaglandin F2 alpha analogs, which increase melanogenesis and melanocyte proliferation, as well as transfer of melanin to epidermal keratinocytes. We use these agents often in the practice as second-line therapies for repigmentation in patients who have more limited involvement. And this is the data published last summer on ruxolitinib cream for treatment of vitiligo. This is the randomized control phase 2 trial. 157 patients were randomized, 139 completed the 52-week study. There were 5 groups, different concentrations, 0.15, 0.5, 0.1.5, once a day, and 1.5 used twice a day. These concentrations were used in the first 24 weeks. Those patients in the 0.15 group who did not achieve 25% repigmentation were re-randomized to the higher groups for treatment. And at 52 weeks, the proportion of patients achieving a facial VASI 75, facial VASI 90, the responses were highest in the 1.5% BID group. At 24 weeks for the 1.5 BID group, it was 30.5%, which increased to 51% at week 52. VASI 90 at 24 weeks was 12, which increased to 33% at week 52. So these are just some before and after images, day 1, week 24, week 52. Obviously, amazing repigmentation at week 52 for the top images. And again, the facial images at baseline, you can see almost complete repigmentation. So ruxolitinib monotherapy produced substantial facial and some total body repigmentation at week 24, which continued through week 52. And there was nearly complete facial repigmentation as assessed by VASI 75, and the treatments were extremely well tolerated with no serious AEs. And then we did a subgroup analysis, and this was interesting. There were more responders for facial VASI 50 were female, less than 50 years of age. Interestingly, the responders had a disease duration greater than 20 years, when many studies suggest that long-standing vitiligo does not respond to treatment, and there were no differences in responses based on race, skin type, baseline body surface area, or disease status. So I think that we're clearly making substantial advances, and this is truly an exciting time for clinicians, researchers, and patients with this psychologically challenging condition. We truly are moving forward and creating a new paradigm for patients. So I thank you for your time and your attention.
Hello, my name is Dr. Valerie Callender. I am a professor of dermatology at Howard University College of Medicine in Washington, D.C. I also have private practice in the metropolitan area of Washington, D.C. First, I would like to thank Drs. Rashmi Sarkar and Mona Kohara for the invitation to participate in this webinar today. And my presentation will focus on what's new in alopecia areata. Alopecia areata is an autoimmune condition that's characterized by a rapid onset of hair loss on the scalp, eyebrows, eyelashes, and even in severe cases, there's body involvement. It has an unpredictable prognosis with relapses, remissions, and persistence of hair loss. It's also associated with comorbidities and autoimmune diseases, and you can have nail involvement with alopecia areata. This inflammatory, non-scarring hair loss has a negative impact on the quality of life of our patients. In some cases, patients suffer severely with anxiety and depression. And currently, there are no US FDA-approved treatments for alopecia areata. Alopecia areata affects approximately 2% of the global population. It is the most common cause of hair loss following androgenetic alopecia. It affects both sexes equally, occurs in all races and ethnicities, and is more prevalent in children. Studies have also shown that alopecia areata is more common in the Black population compared to Asians and whites. And there are other forms that are less common. And this includes ophiasis pattern, and also alopecia totalis and alopecia universalis. 40% of patients with alopecia areata will experience their first episode by the age of 20, and 83 to 85% of patients by age 40. Nail involvement occurs in about 30% of patients, and is also more common in children. The hair follicle itself functions as a mini organ, and it undergoes continuous regenerative cyclic life cycle. The bulge and the bulb compartments of the hair follicle enjoy what is called relative immune privilege, or IP, which protects the hair follicle from inflammatory processes and promotes immune tolerance. The pathophysiology of alopecia areata exists because of this collapse of the hair follicle bulb IP. And this plays a crucial role and why the hair follicle is destroyed. Triggering factors in genetically susceptible individuals. And then there's an activation of the inflammatory response, the innate immune system. And this elicits CD8 positive natural killer cells and also CD4 positive T cells. Interferon gamma response also is part of the pathophysiology with upregulation of cytokines IL-2 and IL-15. However, the hair follicle stem cells in the bulge area is spared. So this allows hair to regrow. So let's summarize. The pathophysiology of alopecia areata is loss of the hair follicle immune privilege, and this leads to infiltration of the CD8 natural killer T cells and the CD4 positive T cells. The CD8 positive T cells secrete interferon gamma and then IL-15 and IL-2, and this is all signaled through the JAK-STAT pathway that occurs within the hair follicle epithelial cells. This inflammatory reaction forces the hair follicle into premature catagen, dystrophy, and eventually apoptosis. This is where the hair follicle is damaged and hair loss occurs. There are various clinical presentations in patients who present with alopecia areata. I commonly see patients with patchy alopecia areata. And these are where you have either one, two, or several demarcated patches of hair loss on the scalp. Alopecia totalis is when there's complete hair loss, and alopecia universalis is when there's loss not only of the scalp, but also the face and the body. The epiphysis alopecia areata is when there's hair loss that is focused on the occipital or the temporal areas of the scalp, and an inverse ophiasis pattern. This is where the lateral and posterior scalp are spared. However, the hair loss is focused mainly on the central area of the scalp. There's diffuse alopecia areata, and which is referred to alopecia areata incognita. And this is where you have diffuse hair loss, and then also just a reduction of the hair density. Alopecia areata can occur in the beard area as well as involve the nails. These are photos of patients with various forms of alopecia areata. You can see patchy alopecia where there's multiple areas of hair loss, alopecia totalis where there's complete hair loss in the entire scalp, and then hair loss in the occipital area, and this is the ophiasis pattern. These are other presentations that you may find in patients with alopecia areata. You can see loss of eyebrows, eyelashes, beard area, and in this patient, you can see there's loss of hair in the axilla. Nail changes can occur. There's nail pitting, trachyonychia, red lunula, transverse grooves, and nail pitting again. The diagnosis of alopecia is really a clinical diagnosis. However, medical history is important. Physical exam, including not only looking at the area of hair loss of the scalp, but the nails. Dermoscopy is very helpful. The hair pull test. We think about using this in patients with telogen effluvium. However, it can actually predict disease activity in patients with alopecia areata. The biopsy is also important. And what you see is a peribulbar and intrabulbar lymphocytic infiltrate, which is mainly made up of CD4 positive cells and CD8 positive T cells. The surrounding anagen or catagen hair follicle is the place of inflammation, and this is what we see histologically as the swarm of bees. So with a dermatoscope, you can see various findings in alopecia areata. In A, you can see that there's just complete hair loss. In B, you see the broken hairs as well as the exclamation marked hairs. That's where the arrow is pointing. In C, you can see black dots, and you can also see some vellus hairs, which are present, and some broken hairs. In D, this is where you see the yellow dots. You can also see some vellus hairs and some broken hairs. The differential diagnosis in alopecia areata in children and adolescents and adults is different. So in children or adolescents, when you see patchy areas of alopecia, think of tinea capitis, trichotillomania, temporal triangular alopecia. In children and adolescents, if you see diffuse alopecia areata, think about the loose anagen hair syndrome, telogen effluvium, and congenital hypertrichosis. In adolescents and adults, if it's patchy, think of mucinosis follicularis, alopecia syphilitica, scarring alopecia, and if it's diffuse alopecia areata in adults and children, adults and adolescents, think of telogen effluvium, female pattern hair loss, and drug-induced alopecia. And when the epiphysis pattern is present in patients with alopecia areata, also think of traction alopecia. And traction alopecia can present in an epiphysis pattern. And one of the clear signs is the fringe sign. So those are the retained hairs that you can see at the periphery. However, if unsure, skin biopsy is important. We tend to classify alopecia areata with this specific tool. It's called the Severity of Alopecia tool, or the SALT score. It's a global severity score that captures the percent of hair loss. It assesses severity of alopecia areata. It guides the physician's therapeutic response. It predicts disease prognosis. It's currently used mainly in clinical trials, but also can be used in clinical practice. It has a score of 0, which means no hair loss, and to a score of 100, which means complete hair loss. Comorbidities and associated autoimmune diseases in alopecia areata include autoimmune thyroiditis, vitiligo, systemic lupus, rheumatoid arthritis, and psoriasis. Currently, I see a lot of patients with alopecia areata who also have atopic dermatitis or atopy. Also psychiatric disorders, as we talked about with the quality of life issues with alopecia areata patients, depression and anxiety also is a concern, and especially in children. Children with alopecia areata frequently are bullied. So we have to remember that the psychiatric component of alopecia areata is very important, and we must, in some cases, refer them for psychological counseling. Other associated findings include vitamin D deficiency, iron deficiency, anemia, metabolic syndrome, and Helicobacter pylori infection. So what about treatments? And currently there are no US FDA approved treatments for alopecia areata. However, these are some of the treatment options that we use in treating patients with alopecia areata. I currently use topical intralesional systemic steroids in patients. Other treatments include topical sensitization and irritation therapy, systemic therapies such as methotrexate, cyclosporin, TNF inhibitors, phototherapy. I also use topical calcineurin inhibitors off-label to treat alopecia areata. Also procedures such as platelet-rich plasma injection has been used, topical minoxidil, and also vitamin D, zinc supplementation. So the JAK-STAT pathway actually stands for Janus kinase signal transducer and activator of transcription. This signaling pathway is a chain of interactions between proteins in a cell and is involved in the processes such as immunity, cell division, cell death, and tumor formation. Activated by cytokines, as you can see in this diagram, and this allows transfer of signals from the cell membrane receptors into the nucleus. JAK inhibitors are small molecules that inhibit the Janus kinase enzymes. It interferes with the JAK-STAT signaling pathway, and there is a block in the downstream signaling of these different cytokines. And the cytokines in alopecia areata are mediators, interferon gamma and interleukin 15. Currently, some of the JAK inhibitors that are being studied include oral tofacitinib, ruxolitinib, and baricitinib. So this is a recent publication that looks at 2 phase 3 trials of baricitinib for alopecia areata. It was published in the New England Journal of Medicine in May of this year. Baricitinib is an oral, reversible, and selective JAK1 and 2 inhibitor. It selectively and reversibly inhibits the interruption of cytokines signaling that is involved in the pathogenesis of alopecia areata. It's approved in over 70 countries for treating moderate to severe active rheumatoid arthritis in adults, and it's approved in Europe and Japan and under evaluation in the US for the treatment of moderate to severe atopic dermatitis in adults. So this study looked at 2 randomized placebo-controlled phase 3 trials, BRAVE AA1 and BRAVE AA2. It included adults with severe alopecia areata with SALT scores of 50 or higher. Patients were randomized in a 3:2:2 ratio into 3 groups, Bari 4 milligrams, Bari 2 milligrams, or placebo. The primary outcome was to have a SALT score of less or equal to 20 at week 36. Secondary outcomes include measures for the eyelash and eyebrow hair loss, scalp hair assessment, percent change from baseline in the SALT at 36 weeks, percent of patients with SALT score of less than or equal to 10 at 36 weeks, and a SALT 90 at 36 weeks. There were 654 patients in the BRAVE AA1 study, 546 patients in the BRAVE AA2 study. The age range the average range was 38 years. Females represented about 58% in the BRAVE AA1 and about 65% in BRAVE AA2. There were white patients, Asian patients, as well as Black patients, and alopecia areata. Usually the duration was around 12 years. The mean duration of the current episode, because remember, alopecia areata waxes and wanes, was 3.6 years in the BRAVE AA1 study and 4.3 years in the BRAVE AA2. The average SALT score was about 85, so these are severe hair loss patients, and 53.2% patients had severe disease, and 90% of the patients had at least one previous therapy for alopecia areata. So when you look at the results, what's important is in the BRAVE AA1 study, there were 38.8% of patients with a SALT score of less than or equal to 20 at week 24 at week 36. And this was in the BRAVE study. And so these are 38.8% of the patients had the 4 milligram dose, 22.8% had the 2 milligram dose, and the 6.2% had the placebo. And this was statistically significant. In the BRAVE AA2 study, 35.9% of patients who received the 4 milligram dose had a SALT score of less than 20 at 36 weeks, 19.4% of patients who received a 2 milligram dose, and 3.3% of patients who received the placebo. And this was found to be statistically significant. What about adverse events? Interestingly, acne was found to be more common in the study drug versus the placebo. UTIs were found to also be very common, well, more common than the placebo. And then upper respiratory tract infections and headache were also part of the AEs. In the BRAVE AA2 study, there were 3 subjects with the 4 milligram dose, 3 subjects with the 2 milligram dose, and 1 subject with the placebo who had herpes zoster. And also the increased creatinine kinase and the levels of the low high density lipoprotein cholesterol was also found to be an adverse event in the study. So in conclusion, Alopecia areata is a chronic immune-mediated non-scarring hair loss that causes emotional and psychological trauma to alopecia areata patients. There are various clinical presentations ranging from patchy areas of hair loss to complete scalp involvement and body hair loss. Current treatments include topical, intralesional, and systemic steroids and interventions. However, they demonstrate varying degrees of success. Baricitinib is a JAK inhibitor and is an emerging treatment for alopecia areata and exerts its effect on the pathophysiological mechanisms in the development of the disease. Long-term 16-week follow-up clinical trials are currently underway, and this is an exciting time for patients and physicians with alopecia areata. Thank you. And I'm happy to answer questions when the Q&A session begins.
Hi, Valerie.
Hi, Rashmi.
Really
How are
nice here.
you?
We're very
Good.
good, here, and good to see you. So that was a wonderful lecture, and I thought we'll break for some questions and answers since you may have to go in between. So I think there are a few audience questions, One that I have for you, Valerie, is from Dr. Niranjan Nagpur. The problem, he says, with treatment is how long to continue the treatment and when to stop, and chances of recurrence with newer treatments. I think he's referring to the newer treatments, which you've just shown for alopecia areata.
Well, I think, that's, the question we're all asking. And like I stated in the conclusion, there are studies now that are long-term studies, extension studies from patients from this study who will roll over. And so I think that is going to be a problem, especially in the United States, because, insurance companies may or may not continue the coverage of this medication. It's very expensive. And so we worry about that. Now, you also have to remember, too, that these patients are in a clinical trial. So you're only using the study drug as monotherapy. So it would be interesting to know how you can prolong that remission if also the patient is using standard traditional topical therapies or even systemic therapies along with the Barry drug. So the results aren't in yet, and we're excited, though, that we have an alternative. And whether we can use this agent in a topical formulation has not been studied, but I'm sure it soon will be.
Okay, so you're talking about baricitinib, isn't it?
Pardon?
Baricitinib. You're talking about baricitinib.
Yes.
Yes.
Because that's what's new right now.
Yeah, that's what's new and all. There's a question also, thank you, Valerie, from Dr. Vignesh Narayan. Is switching between JAK inhibitors effective in refractory alopecia areata? This is something that, other people have also had in mind.
Well, I think you should be able to do it. I think patients who are undergoing these JAK inhibitors for psoriasis probably have a little bit more experience, or rheumatoid arthritis. I don't think we have that data, the safety data, for patients with alopecia areata. But I think if you look at the literature for rheumatoid arthritis, there has been successful transferring from one JAK to another. And so I think with alopecia areata, that would also be the case, should also be the case.
I think, yes, still there's a lot to learn about the JAK inhibitors, and how they work. That is true that we're working. Thank you. There's one question from Dr. Bansal. What is the long-term safety with tofacitinib?
Oh, the data here actually just shows that as far as the long-term safety, you've got to look out for acne. You have to monitor cholesterol levels. The creatinine kinase was found to be elevated, so you have to monitor those as well. UTIs were also found to be more common in patients with study drug versus placebo. So really, it looks like it's going to be a pretty safe medication within a 3-year period, which is according to this study.
So what is the longest period that you've given, Valerie, for tofacitinib?
I currently do not use it orally in my patients.
Okay,
I had used it. Yeah, I've used it topically in a topical formulation, but I have no experience with using tofa in patients orally.
Right. I think maybe Surabhi, you've used it in a few patients and so have we.
Yes, ma'am.
I think we do tend to lose them to follow up, but we've given them, I think, up to about 6 months and on, but
9 months,
sometimes they're
9
not
months,
able to continue. Yes. Right.
6 months?
Yes.
Okay.
But sometimes, they do break treatment. That is there. There's one question. I think that's a repeat that can we use tofacitinib in place of baricitinib? I fought with Lygos topical therapy. I think you mentioned that already.
Yes.
Dr. Sitara, how effective is tofacitinib when compared to baricitinib in alopecia areata? I think you partly answered that, question. Most of them about JAK inhibitors. When you stop it or you switch over to another treatment, Valerie, what is your favorite, switch over drug? Because you ultimately have to stop it, gradually.
Well, I think, corticosteroids still remain, the treatment of choice, whether you're using it topical, whether you're using it intralesional, whether you're using it in systemic. Some patients, we use triamcinolone, acetamide intramuscularly, and we'll repeat that, every 6 weeks times 3. And that has been found to be successful. Matter of fact, that was one of the better treatments back in my residency 30-some years ago. So we still use some of the older treatments. The topical calcineurin inhibitors have been found to be very effective, as well as using PRP, platelet-rich plasma injection.
So I think quite a few questions. Anything else you see coming, Surabhi, or should we otherwise continue? There are quite a few questions, but yeah.
This is it for now.
Yeah. So thank you for, these are the present questions, Valerie. There are quite a lot of curiosity, I think, about the JAK inhibitors,
Yeah.
Thanks
well,
a
thank
lot,
you very much. Thank you.
Yeah.
Thank you.
Such a pleasure. Yeah.
All right.
Yeah. Over to you, Surabhi. You want to tell Naveen to continue?
Yeah, Naveen will be having Dr. Diane Burson's lecture now.
Sure, doctor. Yeah.
Hello, everybody. I would like to thank Rashmi and all of you for inviting me today to speak with you. My name is Dr. Diane Burson. I'm a dermatologist in New York City. I'm on the faculty at Weill Cornell Medical College and on staff at New York Presbyterian Hospital, and I have a private practice in New York. And today I'm going to speak to you about the treatment of acne and what's new in acne. So first, I'm going to speak about topical treatments. As we all know, our first-line therapy for patients with acne are the topical retinoids. And luckily, we have so many options now. But retinoids are first line because they not only help resolve acne lesions that are present, but more importantly, they will help prevent new acne lesions from coming out, basically because they're keratolytic and they help unclog the pores. And of course, retinoids are very helpful for patients who have post-inflammatory hyperpigmentation and for our adult patients who might have some photo damage along with their acne, especially the adult women. The other topical treatments that we use for the treatment of acne are benzoyl peroxide, which is very effective for drying out lesions. There's no resistance to benzoyl peroxide, and it's very helpful for inflammatory acne. And very often we combine the antimicrobial benzoyl peroxide with a topical retinoid for adequate treatment topically for patients with acne. Some of the other therapies that are available topically include sulfone or dapsone, which is an anti-inflammatory, and it's a very nice cosmetically acceptable vehicle. It originally was available in a 5% formulation, but now it's available in a 7.5% formulation. And we very often use this in combination with a retinoid or the other topicals. It's also very nice when applied under makeup for your adult female patient. Azelaic acid actually can be very helpful for patients who not only have acne, but who also have a post-inflammatory hyperpigmentation. And very often for my patients who have post-inflammatory pigmentation as a result of acne, I like to give the combination of azelaic acid in the morning and a topical retinoid at night. And I explain that both of these topicals will help prevent both the acne and further pigmentation and help fade some of the pigmentation. As far as what's new with these topicals, we have had the development of fixed combinations of antimicrobials. First, we had the combination of benzoyl peroxide and erythromycin, and now we have the combination of benzoyl peroxide and clindamycin. And there's synergistic effects. Basically, both will help decrease the bacteria. Benzoyl peroxide has no resistance and helps dry out the acne lesions, but the topical antibiotic added to the benzoyl peroxide can help reduce some of the irritation from the benzoyl peroxide and also has anti-inflammatory properties. And then some patients who have redness do like to use products that contain sodium sulfacetamide and sulfur. As far as the new topical retinoids, in the past we had first tretinoin, which was Retin-A. Then we had the development of adapalene, which was different, and this was a milder retinoid that was a little bit better tolerated with better cosmetic acceptability. And adapalene is a synthetic retinoid that does not have associated sensitivity to the sun and no photodegradation from the sun. For us in the United States, adapalene or different is actually now over the counter, which is very nice for our patients. It's easily accessible and a little bit less expensive. And then the third topical retinoid that became available was Tazorac or Tazarotene, which is also a synthetic retinoid, and that was very effective for pigmentation and helping to loosen up blackheads and whiteheads. As far as the newer retinoids, more recently we've had tretinoin lotion 0.05%, which is a micronized formulation, and it contains something called a polymerized emulsion or a mesh-like network. And with this polymeric emulsion technology, you get this 3D mesh that holds water and helps hydrate the skin, and it helps provide the water-soluble ingredients, such as the retinoid, as oil droplets, which could dissolve and be penetrated into the sebaceous follicle. So it's a very nice cosmetic formulation, again, for our patients who may have dry or sensitive skin and want something that's very acceptable cosmetically, and certainly for our adult patients who may want the benefit of their retinoid for both acne prevention and photo damage. The new tretinoin lotion, which is called Altreno, has hydrating agents in the vehicle, including glycerin, hyaluronic acid, and soluble collagen, so it spreads and absorbs easily. The same company, Ortho, also came out with a new Tazarotene lotion, which has the exact same vehicle, and this is called a Raslo lotion containing Tazarotene 0.05%. It also contains the emulsion technology. It did very well in phase 3 trials, and now we have it available as a Raslo. And my patients have loved both of these as an addition to their armamentarium. Trifarotene is a new retinoid formulation that we have made by Galderma, and it contains trifarotene 0.005%, and the name of this product is Acleef. And this is a 4th generation retinoid that has specific selective binding for the RAR gamma receptor. And in these trials, it was actually shown to be effective for both face and trunk acne and safe to be used for adolescent kids. And although we use all the topical retinoids for face and trunk, Acleef was actually the first to have an approval for both the face and the trunk. So basically, all of these A's, Raslo, Altreno, and Acleef, are nice new retinoids that have nice cosmetic formulations that are very well tolerated by our patients. And since we do want all of our patients on a topical retinoid, they've been very helpful. As far as new combinations, I mentioned earlier that for a while we've had benzoyl peroxide mixed with antibiotics. But more recently, we were able to get formulations that combined retinoids and benzoyl peroxide, which is very effective for our patients with acne and really contains all the ingredients that we'd want to give a patient topically. The first formulation was adapalene mixed with benzoyl peroxide, and this was made by Galderma, and it's called Epiduo. And basically, it was found that Epiduo also caused a decrease in number and size of atrophic scars. So for patients who have inflammatory acne with the potential for scarring, this is a very nice topical formulation to get them to hopefully prevent some scarring. What we all wanted was something that could combine tretinoin and benzoyl peroxide, and it was tested in a dual chamber pump because obviously there could be stability issues. We know that tretinoin can be photodegraded in the presence of ultraviolet light and also can be degraded in the presence of benzoyl peroxide. But we finally do have a formulation that is very stable, and this is also made by Galderma, and it's called Twinio, and it contains tretinoin 0.1% mixed with benzoyl peroxide 3%. And so it basically can be used for the face and for the trunk. And it contains a microencapsulation technology that's a patented technology where the product is released in silicone dioxide shells. And in so doing, the shells create a barrier between the tretinoin and the benzoyl peroxide to prevent degradation in the bottle and degradation in the skin. And so instead of oxidizing, the active ingredients are gradually absorbed into the skin. So this will be a very nice addition to our topical formulation. We also have a topical hydrochloric acid antimicrobial facial cleanser. Basically, this is the idea of using bleach or sodium bicarbonate or hypochlorous acid. It's effective against bacteria, virus, fungus, spores, and MRSA, and also has anti-inflammatory properties. It decreases mast cell degranulation, and so it can be a helpful cleanser for our patients with mild to moderate acne. Here we have Lasersin, which is one of the products that has this ingredient, and the other one is called Clean, and both of these make great cleansers for our acne patients. Another new topical that we've had added to our formulations has been a topical minocycline. And the one that has become proved is the FMX 101, which is a 4% minocycline foam. This contains minocycline micronized in a triglyceride-based foam technology, and clinical trials showed that this product did meet both primary and secondary efficacy endpoints and was very successful in a phase 3 study. And so we now have this product called Amzeeq, which is minocycline foam 4%. It spreads very easily, so it can be used on the face, it could be used on the scalp, it can be used on hairy areas such as the back and chest in men, and it can be used very nicely as a topical formulation. And what's nice about this is that the minocycline penetrates into the pilosebaceous unit down deep into the follicle. And so the patient can get the benefit of a minocycline without having to take it orally. And as we know, some of our patients can't tolerate the oral antibiotics, such as minocycline and doxycycline. Sometimes they get GI upset or certainly photosensitivity. And in the case of minocycline, some patients can get some central nervous system effects such as headaches. So for those who want a topical option, we now have a topical minocycline. Another very new and exciting development was the arrival of Winlevi, or topical clascoterone. And Winlevi is a topical anti-androgen, and we've never really had a topical anti-androgen that was effective for our patients with acne. We have used oral anti-androgens, which I'll discuss in a moment, such as spironolactone and the birth control pill for our patients, our women patients who have cyclical fluctuations of their acne. But now we have Winlevi, which is clascoterone, alpha propionate 1% cream. And basically it functions as a topical, potent, peripherally selective anti-androgen. It targets the androgen receptors on the surface of sebocytes, and I might say also on hair papilla cells within the pilosebaceous unit. And so obviously we are going to be studying this for hair thinning also as a solution. But for the cream, which has been approved, it competes with the androgen receptor on the pilosebaceous units. It displaces dihydrotestosterone from binding. There is no inhibition of 5-alpha reductase, and there are no systemic side effects, so we don't see any interference with the axis, with the HPA axis. So our patients don't deal with some of those potential side effects. Clascoterone also might show a little bit of inhibition of sebum production from the sebaceous follicle by this anti-androgenic effect. And it also can inhibit inflammation or cytokines. And so I've found it to be a very new helpful adjunct for my patients. It's a twice-a-day application, and I have them use it twice a day layered with some of the other topicals that they may already be on, and certainly for those who might need a little bit of hormonal help. And also as a vehicle, I find that it sucks up some of the oil and makes the skin look less oily and gives it sort of a matte finish. The activity of this is actually a little bit higher than finasteride and flutamide, and it has been shown to be equal to cyproterone acetate. So it functions very well as an anti-androgen. And in the clinical trials, it was a very safe and effective medication. It's approved for both women and men. And again, that's because this does not cause adrenal suppression or interfere with the adrenal axis. So I've found it to be a very helpful addition to my patients who are a little bit oily or shiny, or certainly for patients who have hormonal flares of their acne. And I've also found it to be very effective for my patients who I've given Accutane or isotretinoin to, and I want to put them on a maintenance, especially women who may have hormonal flares. As far as antibiotic treatment for acne orally, we now have an appreciation for the fact that we need to exercise some stewardship in prescribing oral antibiotics for acne. I think dermatologists in our country probably are one of the fields who prescribe the most oral antibiotics. And obviously we have to think about the development of resistance to antibiotics. The antibiotics that we currently use for treating acne, as I mentioned, include minocycline and doxycycline. When I do treat patients with this, and they are very effective for rapidly reducing the inflammatory component and therefore potentially the development of post-inflammatory hyperpigmentation and scarring, but I do like to limit it to 3 to 6 months orally. And as a matter of fact, if someone isn't clearing by 6 months on an oral antibiotic, I will usually stop it and think about hormonal additions or certainly isotretinoin. One way you can minimize the development of resistance is by mixing it in combination with a topical benzoyl peroxide, which reduces the development of resistance. We do recommend avoiding topical antibiotic monotherapy, for that matter, even oral, any antibiotic monotherapy. You do want to balance it with something to reduce resistance. And if you're going to give it during maintenance, you want to use other topicals, such as benzoyl peroxide mixed with a retinoid or even azelaic acid for maintenance, so patients don't develop resistance. Now, because of the fears of developing resistance and of course our appreciation for the microbiome, we know that the oral antibiotics that we give our patients can affect other organisms in their microbiome, in their flora on their skin, and certainly other organisms in their GI tract. And so in trying to minimize the alteration of the microbiome and trying to maintain the diversity of the microbiome on the skin, we've had the development of a new antibiotic. It's a new generation antibiotic called sarecycline, or Sera. And sarecycline is a narrow spectrum tetracycline-derived antibiotic. So it's in the tetracycline family, just as minocycline and doxycycline are, but it has a much more narrow spectrum of activity. And so because of that much more narrow spectrum, it's more targeted for the skin flora that may contribute to acne, and it's less likely to affect other organisms. And as I mentioned earlier, the GI flora. And as we do know, some patients do develop diarrhea and some other GI symptoms when they're on the other tetracycline type antibiotics. So this has been developed for those patients. It has anti-inflammatory properties. It's only given once a day, which is nice, and it can be taken with or without food. Generally, the other antibiotics we do recommend have to be taken with food. It's a weight-based dosing. It's available in 3 doses, which is easy because we just see where our patient fits and we just prescribe them that dose based on their weight. And this oral antibiotic is also approved down to age 9. So for your patients before puberty who are in andronarche, who are developing inflammatory acne, and you're worried about giving them minocycline or doxycycline, especially if their teeth haven't developed yet, you can give this antibiotic down to age 9. And it's also approved for chest and back acne. So it's been a nice, helpful addition to our armamentarium. And again, in these trials, it was found to be effective for moderate to severe acne, and both the co-primary endpoints for inflammatory lesion reduction and secondary endpoints were met with a low incidence of side effects. In talking about some of the developments for isotretinoin or Accutane, we now have a formulation called Lidose technology, and the dosage is about 80% lower than our isotretinoin dose. So for instance, if someone was taking an isotretinoin dose of 20 milligrams, the Lidose dose would be 16 milligrams. And if they were taking 30 milligrams, it would be 24 milligrams, et cetera. And the advantage of this Lidose formulation is that it can be taken with or without food. We know usually we recommend that our patients take isotretinoin or Roaccutane with food to have the benefit of maximal absorption. But this is a formulation that can work for our patients who may not be eating as much, and we want to make sure that they get enough absorption to clear their acne. And the phase 4 study of long-term efficacy and safety in patients examined the relapse of patients who took this on an empty stomach and found that 83% required no further treatment. So this Lidose technology is a nice new entity for those who want to take isotretinoin. As far as controversies regarding isotretinoin and what's new, we now know that you probably don't have to delay a lot of the laser procedures that we told patients they would have to wait for. For instance, we used to tell patients that they'd have to wait 6 months to have a non-ablative Fraxel treatment if they developed any scarring. But there really is insufficient evidence to support delaying superficial chemical peels, surgery, laser hair removal, fractional non-ablative laser procedures, and even vascular and pigmented lesion lasers. So I think you still want to wait 6 months for an ablative CO2 laser resurfacing or dermabrasion, but for the non-ablative and the other lasers, it's probably okay to start it sooner than 6 months after completing a course of isotretinoin. And also with regard to blood test monitoring, I think after it's been shown that after we do our blood test on our patients every month, after about the first 3 months, if there has been no change in their lipid or hepatic profile, it's okay to not continue performing the blood tests. Obviously, we have to check our pregnancy for our female patients, but we can do that with a urine test. So it's nice that we don't have to stick them with a needle every month for the entire treatment. Finally, I just want to mention that in terms of treating our female patients with acne, we can take advantage of systemic hormonal treatments. And so when we are talking with these patients, I do like to review their skincare, such as the use of mild and gentle cleansing and the importance of barrier maintenance using hydration and keeping their barrier function intact. I do talk about cosmeceuticals and some of the benefits of using ingredients that may reduce inflammation, that may reduce pigmentation, and of course the use of cosmetics to camouflage their acne. So when we talk about their treatment regimen, we not only discuss topical treatments and oral treatments that I've already recommended, but I do often incorporate hormonal therapies as well as procedures such as peels or laser and light treatments. And of course, I do discuss their dietary lifestyles and some of the newer therapies, such as the newer lasers that we can use. This is a classic presentation of our patients, our female patients, who may be clear and they just get this cyclical hormonal flare of acne on the chin. And I've been seeing a lot more of this since COVID, and I sort of talk about this as being the triple threat. And so in terms of what's new is the COVID issue and the wearing of masks. And for these patients, I tell them the triple threat is that this is where they break out hormonally. This is where they break out under stress. And obviously the COVID has been a stressful time for us. And that the mask covering this area right there increases the heat and the humidity under the mask, and the heat and humidity mixes with the surface oils and perspirations and skincare. So it only exacerbates this hormonal flare, which women often develop in that area. So for these women, we can use hormonal therapies. The birth control pill can be very effective. Birth control pills contain an estrogen and a progestin, and it's the estrogen moiety that usually helps contribute to reduction of hormonal flares and improvement of acne. And it does this in two ways. First, by the negative feedback cycle, it reduces further ovarian production of testosterone. And secondly, estrogen increases the sex hormone binding globulin. So we have less available free circulating testosterone to interact with our sebaceous glands. So the birth control pill essentially reduces the effect of testosterone, which helps the acne. Do keep in mind that there are newer forms of birth control, and it's not just the standard pill where a patient takes an active for 21 days and a blank for 7 days, which is usually when the acne flares, but there are now continuous birth control pills where patients may take the active for 3 months straight and only get a period once every 3 months. And so for that, patients may see an improvement of their acne because they may only break out now more severely once every 3 months, and some who are on a continuous one. But keep in mind that there are patches and rings. And if a patient is using a patch or a ring, they're probably going to get benefits of their acne because the estrogen is being absorbed directly into their bloodstream without having to go through the enterohepatic circulation first. And so they're probably getting more active estrogen. And so in terms of what's new, be aware that these new formulations are available. So when you ask your patient if she's taking the birth control pill, I would now say, are you using any form of birth control? Because you don't want to give her the pill for her acne if she's using a patch or a ring, because you might be doubling the bioavailability of estrogen for her and increasing the chance of her developing a thromboembolic event. Also keep in mind that the IUDs are becoming more and more popular as women are less likely to want to go on the pill. And while the IUDs used to be mostly copper, there are now IUDs that secrete hormone, and the hormone they secrete is the progestin. And so these patients might find that their acne gets worse, not only because they've gone off the pill, but because they're also going on a progesterone secreting IUD. So it's a double whammy. So for these patients, you might find yourself adding in spironolactone. And I've been seeing a lot more of these patients more recently. Spironolactone is a very helpful oral anti-androgen that blocks the androgen receptor, and giving these hormonal therapies will decrease sebum production. I do find spironolactone very helpful for women who have perimenstrual flares, for treatment-resistant acne in women, and to augment the birth control pill for patients who really do have a lot of hormonal flares of their acne. And we do know that it's also helpful for hirsutism and androgenetic alopecia. And then finally, I just wanted to discuss diet. Diet probably does play a role in acne, and that's something that's very in vogue now for us to discuss in terms of what's new. And it seems that the high glycemic index diets that have a lot of sugars and carbohydrates and rice, those patients might find that their acne gets a little bit better if they go on a low carbohydrate diet, sort of the same diet that we give to our patients with insulin resistance or metabolic syndrome or type 2 diabetes, that it might help their acne. Also, skim milk contains milk proteins, including whey and casein, and these whey proteins may stimulate insulin-like growth factor and increase the insulin levels and also contribute to acne. So I tell my patients, if they do want to try some dietary intervention, this is not a standalone instead of or in place of the treatments that I mentioned, but if they do eat a low carbohydrate, dairy-free diet, that they might see some improvement. In terms of cheese, I tell them to avoid cow-based cheeses, but the sheep-based cheeses and goat are probably okay. We do know that there are so many benefits of a Mediterranean diet, high in intake of fruits, vegetables, whole grains, and healthy fats such as omega-3 fatty acids, such as we find in almonds and fish and avocado and olive oil. And we know that this is helpful for any of the inflammatory conditions for our patients with acne, rosacea, eczema, and psoriasis. And certainly I do recommend trying that diet if you have acne. A low glycemic diet will give you a lower androgen bioavailability and hopefully decrease sebum production and inflammation. So I thank you for joining me on What's New in Acne, and I look forward to speaking with all of you in person soon. Be safe. Thank you.
Hello, my name is Dr. Latanya Benjamin. I am an associate professor of pediatric dermatology. I'd like to thank the Indian Association of Dermatologists, Venerologists, and Leprologists and the Women's Dermatologic Society for inviting me to speak at this interesting dermatologic disorders in women and children symposium. All right, so in the next 15 minutes, we're going to talk about what's new in pediatric dermatology. My disclosures include that I am a board of directors for the nonprofit FIRST, Foundations for Ichthyosis and Related Skin Types, and I also sit on their medical and scientific advisory board. Recently, a study looked at the most common pediatric skin conditions managed in outpatient dermatologic clinics in the United States, and they stratified this by race and ethnicity. They utilized a large nationally represented database. And what they found was among the top 3 most common diagnoses managed in skin of color, including Blacks, Asian, and Hispanic youths, were pigmentary disorders. So I thought in this talk, we review some pigmentary disorders that we commonly see in pediatric dermatology and provide some updates. Additionally, in this study, one of the most common skin conditions, as you can imagine, that was encountered was atopic dermatitis. We know that atopic dermatitis is a chronic relapsing pruritic inflammatory dermatosis that affects up to 25% of our children, with early onset between 3 and 6 months of age, with 90%, the majority, demonstrating their skin condition by 5 years of age. As you know, the pathogenesis of atopic dermatitis is complex, and the clinical signs range anywhere from erythema, edema, xerosis with excoriations, to erosions, oozing, and crusting. Atopic dermatitis usually presents with acute flares in the typical locations in the anacubital and popliteal fossa, and also with chronic changes, such as depicted here. And despite the violaceous hue that we commonly see in skin of color, you can also appreciate the significant degree of erythema seen on the legs of this patient. Additional changes for chronicity includes lichenification, and here this hallmarks the intense pruritic nature of this condition. Also commonly seen on the legs is ichthyosis vulgaris. It is the most common form of ichthyosis, often associated with atopic dermatitis, and it has an underlying filaggrin mutation in some of our patients. In general, ichthyosis vulgaris is considered the mildest in comparison with other types of ichthyosis. Turning our attention to ichthyosis, we know that this is a heterogeneous group of inherited disorders of keratinization and is characterized by generalized scaling of the skin of varying severity. Now, in our ichthyosis registry, they've identified they've identified mutations in over 42 genes. However, despite this long list, there's still remarkable potential for new gene discovery. And what's needed is research tools from our registry, as we know that one of the most primary challenges in research in our clinical trial is actually measuring the degree of ichthyosis. So even common looking presentations such as this have mutations in known genes aren't necessarily found in all of the cases. So up until last month, the JAMA Dermatology article finally offers us a new validated scale to objectively and systematically measure ichthyosis severity across the entire body. Myself and colleagues looked at 10 body regions and developed this ichthyosis scoring system, which is hope will be utilized in future ichthyosis research. We know that conditions such as palmoplantar keratoderma or phenotypes and other syndromes or subtypes may have their own unique presentation and not necessarily fit into a standard diagnosis. And so we really need to understand the genetics behind many of our conditions. And thankfully, this new scoring tool also takes into account the palms and soles as part of the body grading classification system. We know that ichthyosis is typically managed by topical retinoids, but oftentimes there's a need for long-term use of oral retinoids because this condition often begins in children. And so this consensus recommendation with myself and colleagues also states a comprehensive review of retinoids for the management of children and adolescents with ichthyosis and other disorders of cornification. And I highly recommend that you take a look at this. It's a very comprehensive consensus statement that offers management guidelines for even the smallest, the youngest neonatal child that requires oral retinoid therapy to our adolescents that need chronic retinoids through the iPledge system. Shifting gears to hypopigmentation, this is a case of a 7-year-old Indian boy that presented to me while I was teaching at Stanford with worsening white spots. Now, I like to include this simple case because it eluded my very astute dermatology residents in training because of the location. And so typical presentation, we would all recognize that this is pityriasis alba, a very common benign condition seen in children with atopic dermatitis. With good counseling and reassurance and mild therapies, the prognosis is excellent. However, I would say the clinical pearl that I would offer here is to whether a patient asks or not, I would address the family specifically that this is not vitiligo and reassuring them. Typically, this is often something that they're carrying into the office on their mind, wondering about. So address that out front, that this is indeed not vitiligo. We know that hypopigmentation and skin of color carries a vast degree and array of conditions, from our most common that we just mentioned to more complicated, such as hypopigmented mycosis fungoides and Hansen's disease. And recently, an atypical variant of lichen-nididus was described. This is a case of atypical lichen-nididus. We know lichen-nididus is a benign skin condition of unknown etiology, classically described on the trunk, extremities, and genitalia of children. However, in this case series, the authors described children that came in with complaints of central face hypopigmentation. And the clinical pearl here is if you look at the actual periphery of the condition, you can see that there are multiple hypopigmented flat-topped papules. So again, vitiligo is a disease in which cutaneous depigmentation occurs, often associated with significant impairment in quality of life. To date, there are no FDA-approved treatments available. And I often do not work up my healthy children for vitiligo unless they're carrying signs or symptoms suggestive of an underlying endocrinopathy or autoimmune conditions such as thyroid disease, diabetes mellitus, pernicious anemia, Addison's disease, or alopecia areata. I typically don't work them up. Here's a case of non-segmental vitiligo and one of segmental vitiligo, which is the less common form. We see this in about 1 of 10 cases, so it's less common than the non-segmental form and tends to appear localized to one area of the body. We do have existing therapies. They're often inadequate and limited. And so there's a lot of investigation around treatment, including the use of topical JAK inhibitors and possible addition of phototherapy. Here's a nice diagram depicting what our current management strategies can be. The first branch is whether you're dealing with non-segmental or segmental vitiligo and whether the disease is stable or not. From the far left of your screen, we'll see the degree of involvement. If it's limited to less than 20% body surface area, we tend to reach for topical therapies. And moving towards the right, when you have more widespread involvement, there could be the addition of phototherapy, or if the disease is unstable, oral systemic corticosteroids, and again, a role for possible surgical correction and grafting. Here's a practical pro I'd like to offer. I love to treat vitiligo of the face or hair-bearing areas in which you can see this nice follicular repigmentation of both the skin and the body hairs. I typically, on the face of children, avoid topical corticosteroids and use a topical calcineurin inhibitor and really see these nice changes. So all the buzz is about the JAK inhibitors for the management of vitiligo. Specifically, we know JAK, Janus kinase inhibitors are a family of intercellular tyrosine kinases that play an essential role in the signaling of numerous cytokines that have been implicated in the pathogenesis of inflammatory disease, multiple diseases. And so there are different JAK pairings that result in different biological significance. And there have been recent case reports and clinical trials evaluating JAK inhibitors for the treatment of vitiligo that are showing encouraging results. We have efficacy data for select JAK pairings of JAK3 TEC and JAK1 and TEAC2. New findings have been published, including randomized phase 2 studies of ruxolitinib cream, and also phase 3 True EV program that enrolled about 300 patients, age adolescents 12 and up with non-segmental vitiligo. And early reports are showing that they have seen in close to 30% of their patients enroll facial repigmentation and at least 75% from baseline at week 24. And also as a secondary endpoint, saw significant greater portion of their patients treated that achieved at least a 50% improvement from baseline in their total body vitiligo area scoring index. So there's some encouraging therapies on the horizon for our patients. And I look forward to our Q&A discussion time together, and we can speak more about this. Thank you for your kind attention.
Hello, my name is Dr. Mara Weinstein-Velez. I'm a board-certified dermatologist at the University of Rochester Medical Center in upstate New York. I'm also the director of cosmetics and lasers here at the hospital. Today, I would like to give a special thank you to Dr. Sarkar for inviting me to speak, and I'll be going over cutting-edge cosmetic dermatology. These are my disclosures. Today, we'll be discussing the science of aging skin. Then I'll go into some trends related to cosmetic derm, look at some combination treatment approaches, and then touch on what's new. So aging is not a choice, and we have to remember this when we see our patients who come to us with their cosmetic concerns. There are many factors that we can't control, but there are many that we can at least guide the patient with, and that includes sun protection, protection with antioxidants against pollution, and also counseling them on their stress levels. So really, when I approach these patients, I take a very holistic approach and try to address all of these things in addition to offering the procedures that we do in the office. Now, a youthful face is defined as having high cheekbones, full cheeks, and a well-defined jawline, as we can see in this daughter, age 26. In her mother, who's age 64, she's starting to display some of these aging features, including flattened cheeks, sagging jawline, and fullness under the chin. Now, in her Indian and South Asian counterparts, so in this population, there have been studies done to show how aging can occur a little bit differently from the typical Eurocentric thought of aging. And so in the 24-year-old daughter, we can see there are some changes across the board that her 58-year-old mother is displaying. And some prominent features that we see in this population include supraorbital hollowing, ptosis of the brow, and also some temporal hollowing, in addition to crepiness and pigmentary changes under the eyes and heaviness in the jowl and lower face. We know that facial aging is not just all about gravity and sagging. There's some complex alterations in bone, muscle, and fat that are ongoing beneath the surface of the skin. For example, we see widening of the bony orbit in addition to shortening of that jawline. We see some movement of the superficial and deep fat pads that lead to that malar flattening that we've seen in both populations that I showed previously. And so when we approach an aging face, we need to make sure we take all these things into consideration, but also counsel our patients on what is exactly happening to their face as they age. So the ASDS, which is the American Society for Dermatologic Surgery, does a survey every few years, and they gather data on its membership as to how many procedures they're doing in each of these categories. And what's fascinating is that over the past 8 years, injectables and non-invasive treatments have more than doubled. And so dermatologists and plastic surgeons are really at the forefront of these treatments. And so when patients come to see us, it's important for us to know how to counsel them and also what procedures are out there to be able to offer them, because we really are the leaders in this field. So when we think about the aging gracefully treatment approach, it can really be outlined into those 5 R's. And these include repairing sun damage, relaxing muscle action, restoring volume, resurfacing skin texture, and re-draping sagging skin. And when I counsel patients, we talk about all these things that need to be addressed and try to develop a maintenance plan. You can see here that the maintenance plan is pretty involved, and this is a way for them to stay on top of their treatments, because after all, we're trying to prevent and keep them away from the knife, which I always say, we don't want you going under the knife unless they want to. So we always have that conversation. But the question really is, how do we optimize our treatment approaches to maximize our outcomes while saving time for the patient? And that's where combination treatments come in. This is really the sweet space. We can get faster and more dramatic improvements in patient outcomes if we use combination treatment approaches. It also tends to increase patient satisfaction with fewer office visits and allows us to develop an individualized treatment plan. Now, on the right here, these are all of the procedures for the most part that we can offer. And so I'll go over ways on how I combine them in my office. But first, we need to think about what is safe to combine and in what order. So there was a study done out of DermSurge looking at the safety profile of combined same-day treatment with botulinum toxin after a variety of full-face non-ablative fractionated laser resurfacing treatments. It was a single center retrospective study looking at 393 patients who received 616 combination treatments. And you can see there all the lasers that were used during these treatments. And afterwards, these patients received treatment with botulinum toxin in different areas, but most all of them received treatment in the glabellar complex. Eyelid ptosis was identified looking at their charts to see if there had been a prescription of apreconidine or a telephone encounter describing droopy lids, or if they had an office visit in the weeks following the injection. And in all of these cases, there was one case of eyelid ptosis identified 13 days post-treatment. And this was after the 1927 nanometer thulium laser. And this patient received 40 units in the glabella, the crow's feet, the platysma, and the forehead. So really, after reading a paper like this, I think that it is safe to combine neuromodulators after facial resurfacing procedures. And I'll tell you how I do that in just a few slides. The next thing to consider is what lasers can you use or what techniques can you use in combination with filler? And if we are using hyaluronic acid fillers, are subsequent lasers dissolving or heating them up, or what's really happening under the skin? And so there was another paper published in DermSurge by Dr. Weiss and his group looking at what happens after 0.1 cc's of HA filler was injected ex vivo into abdominoplasty skin. There was one control. They looked at the different laser wavelengths listed here, and then also looked at fractionated bipolar radiofrequency with insulated and non-insulated needles to see if it had an effect on the HA filler that was injected. Then they performed 4mm punch biopsies. The HAF, or the hyaluronic acid filler, was seen in the mid to deep dermis. The 1927 laser and the CO2 laser did not penetrate deep enough to contact the HA filler. As you can see here in slides G and H, where you can see the damage done to the epidermis here, but really no contact with the hyaluronic acid filler. Now, in the 1540 and 1550 nanometer lasers, thermal damage was very close to superficial portions, but there were no collateral changes. And you can see that over here in slides C, D, E, and F, how you can see the thermal damage here with the laser that was very close to the filler, but there was no real collateral damage. Now, with the fractional microneedling radiofrequency, it did penetrate pre-injected HA filler with histologic evidence of thermal injury to the filler along the microneedle tracks. And you can see here on the far right, that is evident in slides A and B, and then C and D. So after reading this paper, we should take note not to do fractional radiofrequency microneedling procedures post HA filler, but some of our more common non-ablative fractional lasers can actually be safe. And so for a full face rejuvenation approach, in my office, this is sort of the order and the comfort level, I feel, which provides optimal satisfaction for the patient, and also sort of tackles all of the things I mentioned, including those 5 R's in the beginning of the talk. So first, we would employ a skin tightening technique, either using microfocus ultrasound, ultrasound beam array, or radiofrequency. We can treat the entire face and neck in this setting. Then we can do some injectable dermal filler to address areas of volume loss, especially on the jawline and that malar cheek area, and perhaps in the temple area. Then we would do some laser resurfacing. I use a hybrid fractional laser. Prior to using the laser, I would do intense pulse light or a broadband light to help with some of that superficial sun damage and dermatoheliosis. And then at the end, I would do injectable neuromodulators. And so between the laser resurfacing and the injectable neuromodulators, I give the patient enough time. I'll let them ice and sort of let their skin go back to a calm state. And then we'll go ahead and do our injectables. And it had really nice outcomes here. Now, realistically, not all patients can spend this much time at the office, but this sort of technique in this order can be very doable. Now, off the face, we can treat dermatoheliosis using a number of combination treatments. So again, I would start with the skin tightening approach, followed by targeting pigment using these devices listed, and then use some biostimulatory fillers. And here's a video just showing the technique that I use. So here we're mixing a biostimulatory filler, and then we're placing it in the neck in these nice strands. And then we're going to move on to her chest and treat that area as well. And then finally, in a different patient, I'll show you that we use a picosecond laser to help address some of the signs of sun damage, some poikiloderma. And I would feel very comfortable doing all of these treatments within the same session. Now, there have been some newer treatment approaches of acne scarring described where we do triple combination therapy. And there's a nice paper that was written by Dr. Roulan and his colleagues looking at 139 patients with acne scars. And they did carbolic cross followed by subcision and then microneedling, and found really high satisfaction with this treatment approach, that it was safe in darker skin and that post-inflammatory hyperpigmentation was rare. So in my, these are the before and afters, a little blurred here, but you can see some nice improvement with this triple therapy treatment in a darker skin patient. Now in my office, I also do a triple therapy treatment. So I'll just play both of these videos so you can see kind of the approach. So first, we are going to, I use TCA for the cross technique. So I use 80% here. And we will treat the more boxcar and ice pick acne scars with TCA cross, followed by subcision. So I'll use, this here is a 27 gauge needle. Sometimes I use the Norco needle, just depending on the patient and the day. And then I'll follow it up with that hybrid fractionated resurfacing laser. We do this all in the same setting. These patients heal very nicely. We will counsel patients that this will require a series. So we start with 2 and then see how great they do, and then counsel on more treatments thereafter. I also love using combination treatments for hyperpigmentation and dyspigmentation. So I will combine a 30% salicylic acid with 20% TCA, and I'll treat a patient who has PAH in addition to active acne. So here's our setup here. Here's a patient who had some issues with acne excoriae. And so here we are dabbing on the TCA 20 with a cotton tip applicator. And then I'll follow with salicylic acid. And she'll get lightening in the areas of the PAH, and then her skin overall will be calm with little to no acne after the salicylic acid. And we repeat this procedure once a month with really nice outcomes here. And you can see those outcomes here. Now, like I said, she does have acne excoriae, so it sort of feels like we're always chasing her hyperpigmentation, but this is a technique that can be used in other settings as well. Another combination treatment approach I use is for melasma. So here's a patient that has melasma. She also has a nevus of Oda, incidentally, but to treat her melasma, we do a combination of microneedling and chemical peels. And so here we are using, I'm trying to start the video. There we go. So we're using some hyaluronic acid followed by our microneedling technique here on her melasma, and then we're putting the peel right on top. And she does really well with this treatment. And we also use this approach on multiple treatments with the same condition, multiple patients. So what's new? So there are 2 kind of very new approaches in the world of skin tightening and body contouring, specifically cellulite. So I'd like to tell you a little bit about those. There is a new technique called microcoring, and this was just published, you can see in October of 2021. They published their 3 prospective clinical trials looking at this new technique. It is meant to be a method for scarless skin removal without thermal energy. So in theory, could provide some reduction in the skin surface area, allowing for some skin tightening. What's unique about this technique is after these cores are created, there's immediate wound closure, as opposed to some of the mends that are created with our more thermal devices. And so that was described very nicely in this paper. In this technique, they use a hollow hypodermic needle that removes skin, and it's a device that has the needle sort of remove the skin one by one in rows across. I'm sorry, I don't have a video of it just yet, but you can see here the grid that's created in each of the locations. Initially, the studies were done on the abdomen, and then there was a short-term 30-day study done to look at the safety, and then a longer 90-day study to look at the safety and efficacy after employing this technique. Some of the patients appreciated, or most of the patients appreciated an increase in skin thickness. There were biopsy samples to prove that, in addition to tightening, and overall the global aesthetic improvement scores were high. These patients experienced side effects such as roughness, dryness, inflammation, trace PIH, and redness for about 30 days, but it did resolve. Here are some nice examples. Dr. Weibel out of Florida is actually using this technique in her office and has showed some before and afters. Here you can really see improvement of this jowling and the skin sagging. And then also here of these radial cheek lines, and also with the skin sagging post 3 treatment. So this is really exciting, very new, and I hope to get more use and be able to talk about it more next year. And the second treatment here is for cellulite. So we know we have a variety of techniques to use for cellulite, including injectables. There was a subcision device that was used in the past, and there's also acoustic sound waves that are used for cellulite, in addition to various heating modalities. But the newest treatment on the market is this targeted verifiable subcision technique. And what it is a handheld device that helps to subsize the cellulite dimples one by one. Now, what's really nice about it is the patients are numbed locally, and there's one entry point, which is different from some of the other subcision devices that were being used in the past. So here you can see the patient is being numbed from one entry point. All of the cellulite dimples were marked prior to the treatment, and they're using a dilute local anesthesia. And in the pivotal trial, there were 74 women who received a single treatment, and they looked at the primary endpoint after 3 months. This procedure takes about an hour, and 96% of the subjects had improvement. In terms of side effects, 57% had pain or bruising, but there were no serious side effects noted. And I have to thank my colleague, Dr. Green, for providing me with some of this data. And here he is actually treating a patient. So what you saw prior was him putting in the local anesthesia. And here we can see that he's targeting each of those individual cellulite dimples with this targeted subcision device, which is really fascinating. So hopefully we'll have more data on that in the upcoming months. And here are some before and afters from that pivotal trial. So you can see really nice improvement both on the buttock and the lateral thigh 3 months post-treatment. So that's all I have for today. Thank you for your attention, and I'm happy to answer any questions.
Hello, my name is Dr. Jenny Marase, and I'm the co-editor-in-chief of the International Journal of Women's Dermatology with Dr. Dede Morel. Today, I'm going to provide an editor's update for our journal for the IADVL, and I was invited.
Yeah, if Diane is there, Diane, if you're there, would you like to address 1 or 2 questions quickly before you're on the flight? That's why I just halted it.
We're next for takeoff, so I'll do my best. I did text Mona some of the answers.
Yeah, I've got the answers. We're trying to put them in the chat box. No issues. If you want to take any one particularly, you can just quickly do it since you made such an effort.
For the ones that were texted to me by Mona?
Yeah.
Yeah, well, for azelaic acid, which the brand of which I use is Phoenicia, I do use it as a combination regimen. I never use it as a monotherapy, and I find it helpful for mild acne. And I usually have them use the azelaic acid in the morning and the retinoid at night. But that's generally for very mild acne, and I tend to use it more in patients who also have concomitant post-inflammatory hyperpigmentation along with the acne. And I certainly tend to use it more also as a maintenance. So when someone's acne is clear, if they do have residual post-inflammatory hyperpigmentation, that's when I like to use the azelaic acid in the morning and the retinoid at night to help fade the pigmentation and also help as a maintenance to prevent new acne.
So thank you. There's one more question. It's role of topical tacrolimus to decrease acne-related macular erythema, Dr. Shreya.
About tacrolimus?
Yeah.
Yeah, that's what I was saying. You know, tacrolimus is not an approved treatment for acne, and it's more for eczematous conditions. But when we see patients with perioral dermatitis, I tend to use a lot of picrolimus for that. And in theory, tacrolimus could help also. And there is an overlap of perioral dermatitis and rosacea, and it often presents as redness and scaling, but also acneiform papules and pustules. So in theory, it could help, but it's not usually used for that.
Yeah, thank you. Experience with clascoterone, Dr. Vignesh has asked.
Yes, I do have experience with clascoterone, and you know, that's one treatment that's approved for twice a day. And very often when I have treatments that are approved for twice a day, I use them as, I use them once a day in combination with other things, but with clascoterone, I actually am using it twice a day as it's indicated until I get more experience with it and more comfortable. But what I've been doing is almost just adding it into the regimen. So if they're on a regimen already, I might add that in and layer it, almost use that as their emollient. I find that the vehicle has been very nice for patients who have pores and a little bit of oily skin, and it makes their skin look a little bit more matte. In my women patients for whom in my women patients who are taking a course of, let's say, isotretinoin, and I want to give them a maintenance regimen and post isotretinoin, I'll often give them a topical retinoid in addition to a hormonal agent, whether it's spironolactone or the birth control pill. I'm now using this as my post-Accutane maintenance cream along with the retinoid. And I guess I'll see, you know, if I can maybe taper them off the spironolactone faster. I haven't used it long enough, but that's how I see myself using it. And I am giving it to my women patients who have a hormonal component, certainly to their acne. I'm not using it instead of the spironolactone yet. I'm doing it in addition, but I will probably try to use lower doses of spironolactone and maybe try to wean them off of it sooner.
Thank you. So do you have the time, Diane, or you're taking off?
We're number one for takeoff. I'll stay as long as I can.
Yeah, because I think it's just if a patient has features suggestive of PCOD, but the hormonal profile happens to be within the range, how do you manage the patient? From Dr. Brito.
What was that question? I'm sorry.
Yeah, if a patient has features suggestive of polycystic ovarian disease, but the hormonal profile happens to be within the range, how do you manage the patient?
Well, if they have if I perform blood tests and the free total testosterone come back elevated, suggestive of polycystic ovaries, I will refer them to a gynecologist so that they can get an ultrasound and a workup. But usually the treatment for that is an oral contraceptive, a combination oral contraceptive. And the benefit of the estrogen, of course, is to interfere with the HPA axis and decrease the testosterone being produced by the ovaries.
Right. So thank you so much, Diane.
Thank you. Perfect. Yeah. Perfect timing. I'm about to take off.
Yes. Yeah. Great. Yeah.
All right.
Bye.
Bye. Bye. Thank you.
Bye. Okay, so Bharat, maybe we can go to the last lecture of the series.
Yes, ma'am.
Hello, my name is Dr. Jenny Marase, and I'm the co-editor-in-chief of the International Journal of Women's Dermatology with Dr. Dede Morel. Today, I'm going to provide an editor's update for our journal for the IAD-VL, and I was invited by Dr. Rashmi Sarkar to give you an overview of our journal and talk about all the wonderful things that we've done the past 7 years. So we do have a new cover, a new publisher, and a new website, but it is the same address, www.wdsijwd.org, and it is an open access journal, so it does not require Medline access. This is our website, and you can see that there are several key features featured on the top left bar, including articles and issues that include special issues and special collections, as well as different featured content. The featured content includes a collection of blistering disease articles that focus on women's health and their family, as well as a women's health highlight, a patient page that distills the information of the women's health highlight into information that is friendly to share with your patients and is in layman's terms. Also, we have an images and women's dermatology section, as well as an art of prevention series. This is where you would access the latest articles, current issue, previous issues, as well as the special issues. And it does include 2 special collections, one of blistering diseases and one of hidradenitis articles that are very helpful for clinical care. In addition, it highlights other special issues, including our House of Medicine and Dermatology issue that I'll talk about shortly, the Skin of Color and Diversity and Inclusion issue, the Climate Change issue, Gender Gap issue, as well as others. The special collection of blistering disease includes 30 articles, and this collection in particular honors the contributions of Professor Dede Morel, who was one of the founding editors of the journal and acted as journal editor for 7 years. In addition, we have a new House of Medicine issue in December 2021. The co-special issue editors were Dr. Mary Williams and Carolyn Missouri from Yale, and Dr. Williams is from UCSF, and they created 20 excellent articles that have already been very highly cited and downloaded, and this special issue was dedicated to myself. These are the individuals that were on the task force. You can see we have articles that focus on the overlap of dermatology with other fields, including psychiatry, genetics, cardiology, endocrinology, geriatrics, neurology, gastroenterology, public health, infectious disease, allergy, vascular surgery, OBGYN, pediatrics, oncology, hematology, nutrition, rheumatology, and ophthalmology. The first 20 articles had 13,300 downloads in the first 2 months alone. And this was in addition to a second issue in December 2021 of 52 articles. The top 3 articles include the cutaneous signs of nutritional disorders, livedoid vasculopathy, and also the assessment and management of heightened risks for atherosclerotic and cardiovascular events in patients with lupus, erythematosus, or dermatomyositis. We have an international initiative and would certainly welcome any articles from India for the physicians listening. In terms of highlighting the international activities in our journal, we developed a letter from the editors in June 2021 to describe this. Half of our advisory board and editorial board members are non-US physicians. And this is our esteemed editorial board. We have people who focus on issues regarding women's health specifically, medical dermatology, pediatric dermatology, oncology, surgery, and aesthetics, as well as specific sections related to the Women's Dermatologic Society or images in women's dermatology. And these are the esteemed members of our advisory board. We also do have non-dermatologists on our advisory board as well. The climate change special issue in 2020 had 52,000 downloads worldwide. And in particular, one article entitled "The Influence of Climate Change on Skin Cancer Incidence" had 10,000 downloads. This was highlighted in a variety of social media outlets, including the Citizens Climate Lobby. We also had a COVID initiative in 2020 where we had articles specific to women's health related to dermatology and COVID. And these articles were featured in the news. We did have an article that was related to Zoom, the effect in terms of increase in cosmetic procedures that were being requested by patients during the COVID pandemic, as well as an art of prevention article. We were the first article to, the first journal to publish articles on the COVID vaccine reactions that were developed in the skin. And this was featured on News Nation. This is Dr. Karosh who developed the articles talking about the Zoom dysmorphia that resulted from the pandemic. And we were also highlighted on today.com, as well as NECN and NBC. In addition, we have developed articles that also advocate for other forms of social justice, including the identification of skin signs in human trafficking survivors, with detailed photos of the tattoos that may be present on the head and neck in order to identify human trafficked individuals, and have dermatologists help to facilitate their identification and protection. This article in the first 4 months had 1,350 downloads worldwide, also created by Dr. Karosh. We also had a Skin of Color Diversity and Inclusion initiative, and this was a response to the twin pandemic of racism that occurred during the course of the pandemic. And this special issue had 67,000 downloads of the 24 articles worldwide. The Dark Side of Skin Lightening alone had 18,900 downloads, and it's a very popular issue. It talks about the public health crisis related to skin lightening. Also, camouflaging techniques for patients with central cicatricial alopecia was very highly cited among social media sources. 182 different outlets highlighted this article. And one that's particularly helpful for patients with high hair curl index and caring for them when they develop alopecia is an article entitled "The Art of Prevention, It's Too Tight, Loosen Up and Let Your Hair Down." Out of the top 10 articles associated with a social media attention, 5 out of these top 10 were related to the Skin of Color and Diversity and Inclusion issue. And this has been true over the course of the past 2 years. In addition, we did an analysis of the literature and looked at 52 dermatology journals and rated them relative to their content for Skin of Color and Diversity and Inclusion in order to promote this within the field of dermatology publishing as a whole. And we also wrote to specific publications and had letters accepted in order to raise awareness of this issue. We talked about how the Women's Dermatology Society in general feels very strongly about leading within diversifying our field within dermatology, and our piece, Bridging Racial Differences in the Clinical Encounter and How Implicit Bias and Stereotype Threat Contribute to Healthcare Disparities. This received international recognition at the Skin of Color Science Symposium, Shaping the Future of Dermatology, and won that award. We highlighted how throughout the field of dermatology, there has been an emphasis on creating a culture of inclusion, of equity, as well as the fact that we tried to establish criteria in order to create a culture of inclusion within dermatologic publishing. And this was presented at the Council of Dermatology Editors meeting. Our editorial board does address this in the sense that we have very high female representation. 18% of editors-in-chief and 22% of editorial board members are female, but within the IJWD, 84% of our editorial board and 86% of our advisory board are female. A variety of countries are represented, and also we have a variety of race and ethnicity represented on our editorial board. Also, we've promoted authorships when the authors are reported using first names in order to identify female authors. In our publication, 96% of the articles had at least one female author. In addition, we promoted the development of professional female colleagues with 61 different articles related specifically to female professional development. We had an entire special issue on gender gap that was very highly cited in January 2020. And we also did a survey to look at the impact of gender on mentee and mentor success through the WDS Mentorship Survey in September 2021. We also specifically looked at our female skin of color colleagues and had 18 articles specific to the WDS Diversity and Inclusion Initiative. And within the skin of color special issue, those 24 articles, there were 51 articles that related specifically to skin of color and high hair curl index patients and caring for that population. In addition, we've advocated for increased LGBTQ content with 4 articles to support sexual minority, gender minority, and transgender patients. Our latest Scopus data show that our site score in 2020 ranked us in the top 72nd percentile. We were ranked 28 out of 103 dermatology journals within this analysis. And in comparison, we were in the 51st percentile in 2018. So it's really quite rapidly increasing. We have very high site score relative to other publications that have been around for many more years than the IJWD. These are members of our editorial board and advisory board. And just to highlight the different things that we have done, at least over the past 4 years while I've been a co-editor-in-chief with Dr. Morel, we developed the Women's Health Highlight, the patient page that distills the information of the Women's Health Highlight to information that you can use in your practices. We developed the Art of Prevention series to talk about preventative medicine for women and their families, and also the Images in Women's Dermatology section with great images. In addition, we've had special series and a special issue on surgery and cosmetics, the gender gap that was mentioned, climate change, COVID and women's health specifically, the skin of color and diversity inclusion issue, hidradenitis and blistering disease, the House of Medicine, and we have really advocated for the development of a culture of inclusion. And it really is ultimately the development of a culture of inclusion, which is a strategic initiative that is purposely and thoughtfully executed by the editors and editorial board members that brings change to our society. Editors have a great responsibility deciding what information is disseminated to medical professionals and the public in a peer-reviewed platform where potentially more weight is placed on the validity of the findings published due to the rigorous review process for the published articles. It is easy to state that the inequity in our literature is not being addressed by the stream of articles submitted to the journal. But what if, as editors, we take the initiative to invite publications that directly address this inequity in our literature, or to encourage research that would address these inequities, or to welcome voices that would otherwise be unheard? The best counteraction to discrimination of populations who have been marginalized in the past is to be intentional in preventing the discrimination from continuing. The onus is on us as journal editors to create a welcoming and inclusive environment that embraces our differences and is enriched by the knowledge and insight that results when these differences are identified, classified, analyzed, and studied. Diversity is important, but the development of a culture of inclusion on our editorial boards, in our authorship, and within our publication is the key to unlocking new material that benefits both the majority and the minority, the male and the female, the mainstream and the marginalized. Encouraging the voices of the marginalized is the essence to what it allows for the creation of this culture. Therefore, fostering a culture of inclusion is vital to gaining access to the benefits of diversity. Let the marginalized of the past be heard for all of us to reap the benefits of inclusion. So we look forward to welcoming your work, your ideas, and we'd love to publish. So for those that are interested in addressing the topics that we discussed today, anything related to women's health and essentially the health of women and their families, we welcome your work. Thank you so much for your attention.
Yeah, I think there are a few Q&A, and then Mara is still there, and so is Latanya, Surbhi.
Yes.
So I think we could take a couple of questions. Latanya is also there.
Yeah.
So do you have any questions for Latanya from the pediatric dermatology one? I'm trying to just find the questions. There are a couple.
Dr. Mara can take up the cosmetic dermatology ones till next.
Yeah, there are many, but I think I wanted to ask, Latanya, Latanya, what is your experience, with JAK inhibitors overall, in childhood, both atopic dermatitis and vitiligo, because these are two of our go-to conditions. And how long do you give them safely in children, and how do you stop them? That is the thing. What do you roll it over to, which therapy?
Thank you again for your kind invitation to be here. I think these are exciting new drug developments and therapies that we can offer our children. We're still in the process of waiting for them to be FDA approved in children. Currently, there are phase 3 studies investigating adolescents, so age 12 and up. And like most of our drug developments, when you have approval in the adolescence group, then they can march on to younger ages. As far as treatment in the pediatric population, the experience usually would be to reach for the topical therapies first to minimize the risk of side effects that are known in this group or drug class. And then we march on to oral therapies. So in vitiligo, really excited about using at least the first FDA approved ruxolitinib cream, the 1.5%, and we do that twice daily, and really looking forward to seeing those effective changes in our children.
So thank you so much. We'll come back to you, Latanya, with the questions. I'm going to ask a few to what's come for Mara. So Mara, I think there's one question for you. Do threads have a good risk to benefit ratio? Somebody's asked you.
The question is about threads, is that correct?
Yeah, that's true.
Threads. Yeah, so actually I don't use threads. I've used them in the past very minimally. And I do know some of my colleagues are using them as part of this combination treatment therapy where they would do them at the very end. From what I've heard and read, the longevity is an issue. They don't really last that long. And so I'm not sure that I would, integrate them into my practice specifically, but, I think it's sort of I don't know, shot in the dark. Some people use them, some don't, and they're very trendy. So they come in and out of the office.
Right. Mona, in case you want to pitch in anytime, please do, So just like that. There's another question from Dr. Vignesh. Is micro-Botox effective?
Oh, absolutely. I think, there have been a number of studies showing the benefit of its use for various conditions, even hyperhidrosis, rosacea. It's been used in the mid-face and shown to be very effective in that setting. Micro-Botox can also be considered as part of this prejuvenation protocol where younger patients, in their early 20s, to 30s are using it. For that sort of pan-facial rejuvenation, but starting at an early age and using very small doses. I do use that prejuvenation sort of technique. Typically, I don't treat for rosacea and hyperhidrosis, but have read about it and have heard colleagues, say that it works really well.
So I think, it's something that should be explored definitely for rosacea also, because I think last time Dr. Kavita had shown a very good presentation also, I think it was Dr. Erin Gilbert who showed, about using micro-Botox for rosacea. That was a good one. There's another question that could PRP serve as a filler, platelet-rich plasma?
PRP serve as a filler, is that
correct? Can it possibly be a filler, serve as a filler?
Yeah, so, a lot of I don't use it specifically as filler, but I do use it combined with microneedling. And what we have left, one very beneficial use of it I found is to inject into non-healing areas of acne excoriae, for example. So After treatment with microneedling, I will then inject into the areas that have been excoriated, and it helps to expedite the healing in that way. In terms of filler, I've heard it used quite often as, a means of tear trough filler. I think just by, the growth factors and stimulating collagen in that manner, it can help, but I don't know, the long-term benefits of it as a filler specifically. Perhaps it's being used in India as filler, I'm not sure. And I'd be interested to hear, like, Mona, do you use it as filler at all, or is that? Yeah, I just think we don't know enough in that category. I use it a lot for androgenetic alopecia, and as I mentioned, for microneedling, and as a means of expediting wound healing.
True. For acne scars, melasma, that's
Correct.
another area that I'm using, but it's a good adjuvant, I would say.
That's right.
So the other question I can see is, any of you could take it actually. This was a question before. Is there any role of tranexamic acid in erythematous scar? That is, they're talking about the scar of acne. If Mona, if you're using it, or even Mara, if you're using, or Latanya, anybody is using it.
I can just chime in very briefly and say that, tranexamic acid for me is more hyperpigmentation as opposed to erythema. So when there's disease processes that are based in hyperpigmentation, such as melasma, post-inflammatory hyperpigmentation, particularly dermal melasma, which is, notoriously recalcitrant to traditional topical therapies, that's when it's more invoked or used in my practice. Very less likely to be invoked or used with erythema, more pigment.
Right. Any other questions that you can see here? Survey, which there was something on cosmetic dermatology. Yeah. Latanya, you had mentioned actually the hypopigmented spots, in that child, the different macular lesions which are there. So when you get those, macular lesions, hypopigmented ones in children, we see them quite often in the Indian setup actually. What are your common differential diagnoses? Because we do think of things like, pityriasis alba, maybe polymorphic light eruption, and we don't straight away call it vitiligo because that has to be really depigmented. That is one thing. So do you think that, here dermoscopy helps also?
I'm sorry, what was the last part of your question? I think?
Yes, so what would your differential diagnosis be, for these hypopigmented macular lesions in a child, let's say on the arm?
And the role of
differential
dermoscopy. And the role of dermoscopy, Latanya.
Yeah.
Yes, thank you. Those, my differential is vast for any hypopigmentation. I mean, it could go anywhere from a genetic condition like piebaldism all the way to Hansen's disease, leprosy. So typically I'm looking at the morphology of these hypopigmented flat lesions, like are there scales to consider tinea versicolor or something along that line? Is there some scant reactive erythema like in nevus anemicus? Has medications been tried like a chemical leukoderma? So I'm considering at least 12 differential every time I see white spots. Typically, vitiligo, as you know, is a clinical diagnosis. You can spot it from across the room, especially if they're darker complected. I do see skin of color of all types from Fitzpatrick 126. So for the 1 and 2, I will bring out the Woods lamp. And so that is very helpful when you're considering, is this just pityriasis alba or is it truly depigmented? And clearly, sometimes it's a hard call, and we try to minimize invasive procedures like biopsies in children for these common diagnoses. But there's typically a clue on the patient overall, right? So if we're thinking of pityriasis alba, they typically have generalized body xerosis. There's typically perhaps a history of eczema. They're scaly other places. So there's a lot of clinical clues that really narrow down or exclude many of the other differentials.
Right. So thank you so much. There's one question I think left, which is for Mara only, that does botulinum toxin injection for the face lead to osteoporosis of the jaw? Somebody's written.
That's an interesting question. Osteoporosis of the jaw. That quite honestly, I'd have to look that up and get back to you. Yeah, that's a great question. Nothing that I've come across in my clinical or literature research has mentioned that, but thank you for that question.
Right. So I have a question, for Mona. I think it's also for the viewers. The International Journal of Women's Dermatology, Mona, is something that the Women's Dermatologic Society can be truly proud of. It has done very well. It has articles which are quite state of the art. It has special issues, the latest being the one from the House of Medicine that many of us collaborated, in reviewing. And it's come up a long way. But overall, the only issue is that it is also a paid journal. So in any way, does it restrict, getting articles from developing countries, or even if they're not developing, sometimes it may be difficult to pay that amount, because many people do not really have institutional support. In fact, most don't. So that was something, because before this, there were articles, all over the world globally.
Yeah, so it's always been actually a journal that has been, the model with the journal is actually always one that has required payment. Just different publishers have different ways of approaching that. And our new publisher, which is Walters Clore, upholds a different kind of model and giving waivers, et cetera, to helping with this. So it's certainly something that the governance committee, which manages the finance of the journal, is looking into. It's an issue we're aware of.
I know. So maybe that's what has to be done. But for those, who are not aware, the International Journal of Women's Dermatology is a great journal, really has some wonderful articles and different special issues. And I've been on the editorial board for quite some time, and it's worth reading into. The articles are definitely a niche in their own. So please do look up the articles, and you can always collaborate and send, if you're not able to really do it together. That could be one way of, getting across the problem, right? So before we wind up, it's been wonderful having you people, and, thanks for joining. I know that it's a Sunday morning, but I'm sure that this is something that, our IADVL members and even your WDS members, quite a few people have joined. This collaboration is just great. I simply love it. And before we wind up, Mona, is there anything that you would like to tell us before I hand it over to Dinesh Kumar, our Secretary General?
Absolutely. I just want to emphasize the fact that this type of collaboration is exactly what the WDS stands for. It's not, about women in the United States. It's about women and our families and our patients and as colleagues across the world. So the initiative that Dr. Rashmi has put together here is something that really espouses our values. And we encourage this not to be the end point, but the starting point of future collaborations together. Thank you for having us, and congratulations to you on an extremely successful, wonderful webinar.
Yeah, thank you so much. We had almost nearing, almost 500 viewers or something. Good number from IADVL and WDS, and it's a busy Sunday evening, for India with a lot of programs. Thanks, Mona, under your leadership, we had this absolutely great program. More success to all of you in the 49th year. And thanks, Latanya, thanks, Mara. And I'll now hand it over, to Dinesh Kumar, our secretary, to wind this up. And of course, thank our sponsors, which is Regalis. Thank you for the support.
Yeah, thank you, Rashmi Madam, for the wonderful session that you have organized, and also a special thanks to Dr. Mona, President of WDS, for collaborating with IADVL. And here I would like to state that IADVL is one of the largest associations in the world. We have a very strong membership of around 14,600 members in our roles. And this viewership, though it's a Sunday, it's around 9:30 p.m. around here in India. And it's been a pretty good viewership consistently throughout the entire session. And we have had a lot of people posting in our WhatsApp groups about the usefulness of this program. And there has been something for all people in this program. And it's been a really a beneficial program, I would say. And this is something we would definitely look forward in the future also to have more collaboration on much larger scale. And I would like to thank Dr. Mona, President of WDS, for this wonderful partnership, and also the speakers, Dr. Latanya, Dr. Mara, and the other speakers, Dr. Pearl, Dr.
Valerie,
Diane, and Dr. Jenny, Valeria. So thanks a lot for being with us, and we look forward for much more collaboration. And I would like also to thank the efforts that have been put in by Dr. Subi Sinha, the convener of the Leadership Pipeline Program of the IADVL. She's been very steadfast in her contribution to IADVL. And one thing I would like to say is there has been a lot of talk about how Women's Dermatology Society is just for women. But Dr. Rashmi Sarkar has taken a lot of pains to say that it's not all inclusive society as such, but it is like something which opens doors to a lot of things. And the Indian Women's Dermatology Society also opens membership to men. And there are a lot of men speakers also in their scientific meetings. And this is something which is not like closed doors or highly what do you say, close to a meeting or a society, which is open to everyone, and everybody is welcome to contribute here equally. With this note, I would like to thank you all, and also I would like to thank Mednit for their technical support and Regalis for the sponsors. Anything would you like to add, madam?
Yeah, I'd just like to say maybe this is one small positive of the post-COVID, pandemic thing, that, getting these online meetings, which are great collaborations. Of course, we'd had to work for this also, but maybe this is one good thing that, we've had from the COVID pandemic, coming nearer, coming closer. It's been great having you, ladies. Please enjoy the rest of your, Sunday, what is left.
But we would like to have them also to visit India sometime, and we would definitely like to host them. Dr. Mona, Dr.
We have invited them, yes, especially Dr. Mona, we have invited, and the others too.
Thank you.
Thank you. It's so great to collaborate and participate.
Yeah.
Thank you.
Bye-bye.